and if it's like last webinars, people will join over the next few minutes. So very pleased to welcome everybody to this 6th seminar in the series held by BESSY, Behavioural, Environmental, Social and Systems Interventions Collaboration. My name's Susan Mickey and I'm a Professor of Health Psychology from University College London in the UK, and jointly with Jeremy Grimshaw from Canada and Paul Glasziou from Australia, we've begun or taken the initiative of this collaboration. And I'll just say a few words for those of you who haven't been at one of our webinars before to explain what it is and what our vision is. So can I just move it along, sorry. This is the front page of the website. And on the very front page, you'll see we have this scorecard of the number of registered trials that are either come under BESSY, any trials that do with behaviour, environment, social or systems, 11 of them compared to 1,725 pharmacological trials. And of those who've actually reported the results, we have only 3 from BESSY and 213. So that gives you an idea of how little research funding there is in this area compared to how important it is. And a previous speaker at one of these webinars has done research showing that actually only 4% of global research funding has been in BESSYs. So this is partly what we're trying to do, is raise awareness about it, foster collaborations, and importantly, seek funds to right this wrong. So here are the breakdown of the different countries where these have been located. So you can see they're very global in patterning. So we're a global interdisciplinary collaboration, and we aim to foster research, but also importantly, it's translation of evidence into policy and practice. So very much bringing together those people who are responsible for implementing research as well as those generating it. And our primary objective is research to reduce viral transmission, to achieve zero COVID-19 with maximum effect and minimum disruption. The longer term objective is to reduce the likelihood and impact of future pandemics and to help build back better. So this is the 6th webinar, and we called it Learning from International Success during COVID. And delighted to have, actually we have 3 speakers listed here, but I think in fact we're going to have 5 from Africa, and really excited and looking forward to hearing this. In January, we're going to have another webinar, which will be bringing together the learnings of these webinars and thinking about the future. So very much a consultation. And I hope that all those people who've participated over this series will be able to join us to brainstorm about how to take it forward. Here's ways of contacting us, the URL of the website, our Twitter account, hashtag, so anybody who'd like to do any tweeting about today's talk, please do so, and an email contact. Just in terms of how to take part in the discussion, unfortunately our setup means that we can't have people's picture, but if in the Q&A section you just either type in your question or just who you are and your country, and then we can unmute you and bring you into discussion. So do this at any time during the talks, and then whoever will be facilitating the discussion, I think is Jeremy, will be able to see those and bring you in as and when. And now I'll hand over to my colleague, Paul Glasziou, who will introduce the speakers. Would you like me to stop sharing, Paul?
You might just leave it up there for a moment, Susan. Okay. It's my pleasure to introduce the 3 speakers. The format for the webinar, as in previous ones, is that each of the speakers will speak for about 5 minutes, and we'll break then for 3 to 5 minutes of questions, but leaving plenty of time, usually around 20, 25 minutes at the end for a general discussion as well. So Susan, if you'd like to stop the sharing, I'll just introduce the first speaker, who I believe is a couple of colleagues who's going to speak with her, and that's Mariam Shamanish from the African Health Research Institute, and she studies complex interventions and has been doing work in COVID in South Africa, and she and her colleagues are going to talk about their experience now. Thanks, Mariam.
So I'm going to attempt to share my screen. I'm hoping that you can see it.
Yes, that's what's going.
Brilliant. Do you see these pictures? I'll get rid of these as well. Okay. So first to thank the organisers really for inviting us to speak on behalf of the Africa Health Research Institute. It's myself, Dr. Zuma, and Dr. Chimbindi who will be talking today from the Africa Health Research Institute. Just to say that we are actually part of a wider and very active research consortium that was established in KwaZulu-Natal, South Africa. You can see that on the map. At the start of COVID-19 as a response, it's actually the first time that all the research organizations in KZN came together to work very actively. You'll hear from colleagues from South Africa MRC and the HSRC from South Africa later after me in this presentation. But we have had some, because of this collaboration, we ended up being able to have some influence on policy in Durban, in KZN. And in fact, Tembi, who talks with me, is on the KZN Health Promotion Committee as a result of this consortium. So I think we did have some immediate pathways to impact. In RE, we have a very strong youth-led participatory research agenda, and this is an area which is rural with a high burden of HIV and unemployment. We use this approach to develop Tetanami for HIV prevention. In this situation, area-based pairs of peer navigators organize young people in their communities and conducted structured assessments to tailor their health promotion, referrals, and risk-differentiated peer support. This, as you can see very quickly in this, during a 9-month pilot, actually had very wide reach, reaching 3/4 of all the young people living in our district. However, of course, on the 26th of March 2020, the national state of disaster was declared due to COVID-19 pandemic in South Africa, leading to a 1-month nationwide lockdown. As you can see, all non-essential movement stopped, alcohol and tobacco was banned, until test, trace and isolate capacity was set up. Since then, there's been a phased easing, but physical distancing and mandatory masks remain in action, and schools reopened in phases. So I'm handing over to Tembi, my colleague, to talk about adapting virtual support to optimize peer support.
Thank you, Miriam. I'm hearing an echo properly. Am I audible, Miriam? Okay, thanks.
Yep.
Good afternoon, everyone. So Tetanami face-to-face support was terminated at the beginning of the lockdown in March, as Miriam had already said, and peer navigation was adapted to be offered virtually using telephone calls, SMSs, or WhatsApp to support young people's clinical and social needs remotely. Next slide, please, Miriam. Using virtual platforms, peer navigators were able to reach about 75% of the young people that they supported. Smartphones enabled young people to maintain and develop their social network. Through Tetanami, peer navigators were able to refer young people to different facilities for social as well as health needs, and this facilitated resilience. We learned that peer-led community-based care is a versatile model which can be used to decentralize health and social care. Next slide, please. However, there were challenges which included the loss of physical contact, which was essential for interacting with many young people, as there were those who could not afford airtime, or data, or were not able to connect due to poor network connections. Young people also lost privacy within their homes as the physical space became crowded due to the lockdown. Loss of income further disadvantaged young people who were mostly concerned about navigating adulthood. COVID-19 information on the media was not available in the local language, which is isiZulu. It was only available in English. And rumors were also spreading, making young people wonder about what the truth is about COVID-19. So our lessons were that appropriate tools such as phone data are needed to adapt peer supports, and that blended virtual and physical supports may be needed to meet the needs of all young people. Lastly, social and structural interventions are also needed to respond to young people's needs during pandemic. I'll hand over to my colleague, Natai. Thank you.
Thank you, Thembelihle. So I'm going to talk about the role of schools during COVID-19 in rural KwaZulu-Natal. So there were widespread concerns around the negative impact of schools closure on learners, their safety and risk of returning to school. The aim of our study was to understand the role of schools in protecting school-going children from COVID-19. We conducted a qualitative study to understand the perceptions and experiences of schools' response to COVID-19 during and after lockdown. Next slide, please. There were mixed feelings regarding learners and teachers returning to school, particularly those with comorbidities. There was also fear of contracting COVID-19 whilst commuting to school using public transport, as it was hard to ensure prevention measures were adhered to. However, some felt schools were safer places as learners could be monitored and educated on COVID-19 prevention measures. There was also support for feeding schemes that continued during lockdown, illustrating the social role that schools played. Small classes to encourage social distancing provided better learning experiences and identification of children with learning disabilities, while the daily COVID screening helped identify children with non-COVID related needs and vulnerabilities for onward referral. However, some community members felt the Department of Education did not prepare enough learners and guardians for the return of school children to schools, relying on social media, television and radio, as my colleague Thembelihle has already said, for COVID-19 prevention messaging. The smaller classes meant more classes to teach for teachers, which increased their workload and increased the stress on the teachers. I'll hand over to Miriam to do the conclusion. Thank you.
So in conclusion, youth are a rich resource in the COVID response. Not only did virtual support mitigate some of the lockdown harms, but it also allowed youth to construct productive identities and created jobs. However, virtual support needs resources, phones, data training, and the services to refer to, including health and social services. Some physical support is needed for those harder to reach. Similarly, schools played a valued social role during the pandemic in rural South Africa, but they also needed resources and support to achieve and sustain this role. It finally leaves me just to thank our funders and, of course, the peer navigators and the young people who participated in the process. Ready for questions?
Thanks very much, Mariam. I might ask you to, thanks, Mariam. You seem to have an echo on your line, so we just have to be aware that everybody else has to mute for you to be able to speak. That's a fascinating set of work that you've been doing. I think we're a little over time, so I'm just going to ask one question, and that's about the peer support, which looks fantastic, but I was wondering, did you also look at the impact of the peer support on the adherence or the correctness of the NPIs, the non-pharmaceutical interventions?
Thembi, do you want to talk to that? Because I think you have quite rich data on that. So what the peers were telling us about their role in being able to support the public health intervention.
Thank you for the question. So the role of peer navigators was also to refer young people to other departments, such as the Department of Health, as well as the Department of Social Development. So there were a lot of young people who were coming to peer navigators to ask for health-related supports as well as social-related supports during the lockdown period. And moreover, young people were also coming to peer navigators to seek COVID-related information, as well as to seek COVID-related resources in terms of information, in terms of where they could go if they noticed they had symptoms or a family member had symptoms to COVID-19. I don't know, Miriam, if there's anything you want to say in addition one at a time.
No, I think,
Okay, thanks very much for that comment. So it sounds like it had an impact both on the NPIs, but also on the knowledge about appropriate screening as well. Great to hear.
I mean, I think just to add to that, I think one of the things we found is they were also very much worried. They became very anxious. They took on a certain role in terms of anxiety around other young people not adhering to NPIs. And in the small debriefings, a lot of the debriefing sessions were around what they could do to ensure that their friends were wearing masks, and concerns that the other young people weren't adhering as much. So they took on a slightly sort of policing role in their communities.
Thanks. And just a reminder to everybody, please type in your questions or comments into the Q&A section as we go, because we'll come to them when we come to the questions. So I'd now like to introduce our second speaker, Dr. Andrew Gibbs, who's the Senior Specialist Scientist at the Medical Research Council, and he's going to talk about the impact of lockdowns.
Thanks. Let's get that up. Okay, there we go. Thanks, everyone. So just to give you a little bit of background, the Gender and Health Unit is one of many units within the MRC. So we're obviously very focused on gender, and in particular violence against women and girls. So most of the work that we've been doing has been around understanding the impact of COVID around violence and access to health services for kind of young women especially. And I think we're the largest unit in the Global South focusing on violence against women and girls, and typically do lots of intervention research in South Africa. So I'll just talk about 3 studies that we've got going at the moment. The first one is a much more classic qualitative study where we did, led by my colleague, Dr. Pinky Mfahlangu. We did interviews during lockdown. So in South Africa's lockdown, as it eased off, we started doing kind of in-depth one-on-one interviews with men and women, mainly in Gauteng province, really about the impact of lockdown around both mental health, livelihoods, and their experiences of violence, both in relationships and around children. We've started our analysis. I guess generally it kind of follows what lots of people have been saying. There's obviously a huge kind of differential impact by class. The middle classes, the upper middle classes, if you didn't have kind of lose your jobs, there's very little kind of economic impact. But for those who are poorer, major kind of economic impacts, and obviously that runs across kind of other impacts as well. I guess some of the interesting things that we hadn't realized we picked up, but we did. Anxiety, I guess during the most severe lockdown, when we were told very clearly to stay at home, stay inside, people could get with it, could understand it, and it kind of controlled their anxieties around acquiring COVID. As lockdown eased and the rules became relaxed, lots of arguments between couples and in families around what was appropriate and what was not appropriate in terms of mobility, in terms of kind of risk taking started to pop up. So it's one of these kind of moments where the control that kind of severe lockdown gave a bit of a moment of buffer, and as it eased off, it got a bit more complex. I guess for many of the poorer households, I think South Africa's got a very long history of poverty and kind of major challenges. And for some of the people we spoke to, they really spoke of COVID as a tipping point. They've been managing to make ends meet and struggle and kind of make do. But COVID seemed to be the moment where things tipped over. So it's whether we have these much longer term kind of ripple effects. in terms of household violence, I guess we've seen all the evidence from across the world that violence in relationships increased. We struggled incredibly to get people to talk about their own experiences of violence in households on the phone. And I guess we've done lots of face-to-face work, and this is kind of one of the limits we started to realize of telephone interviews. We got a lot more stories about other people's experiences of violence, though. I guess the other area of kind of conflict and tension we found was within kind of violence towards children, and lots of issues around anxiety about controlling children, keeping them inside. And I guess this is what we're seeing as we move into the second wave, and Europe had seen earlier where younger people started going out a lot earlier, you know, and trying to make connections. And I guess the impact of alcohol, we had, as Mariam said at the start, a very strict alcohol policy to begin with, and that seemed to limit the impact of alcohol in relationships. People only had a small amount of alcohol to begin with, and it took a while, we think, for kind of illegal networks to get going. So as we go on, we'll obviously be thinking about and understanding how risk was perceived and how this kind of shaped behaviours. So that's one of our studies. The second study, which has only just really commenced, it's led by my colleague Jill Hannes-Hancock, and what they're doing there is kind of tacking on, doing a sub-study which was going to be looking at access to PrEP, so pre-exposure prophylaxis among young women. And they'd started that project, and during lockdown, they changed it over and included an assessment looking at young women's access to sexual and reproductive health services, and also experiences of violence. So that's a mixed methods, quantitative and qualitative cohort. Unfortunately, they've only just finished the initial kind of first round of follow-up data collection, so we don't have results yet, but they hope to be continuing this over 12 months. So as we go through second and third waves potentially of COVID, they should have some really interesting and important data about how it blocked access to health services. Final one I just wanted to quickly touch on is something that's been led by myself and my colleague, Dr. Geneviève Manel, which is funded through UKRI collaborative grant. I guess what we've done here, instead of talking to young people directly, we're using what we're calling an expanded story completion method. Basically, we're getting young people to create characters, and over the next, I think, 8 to 12 months, we're going to get them to start reflecting and building these characters out into kind of stories of young people in their community. So we're working with 2 groups of young people, urban informal settlements around Durban and rural communities just past where ARI is based. I guess one of the main projects there is to look at young people's experiences of mental health, violence, substance use, and how context impact that. COVID will be one of the key impacts that traces through. And I think by getting people to tell stories which aren't directly about themselves, but about young people in their communities, we're hopefully going to be able to see a slightly more complex and open kind of discussion around the impacts around COVID. And I think really, as well as the second wave comes through, and it's got a lot more, we seem to see at the moment, young people testing positive. What we hope to do is able to look at how these young people, through the stories they tell of the characters they've created, how it impacts kind of their lives in multiple ways, and how it impacts around non-pharmaceutical interventions, wearing masks, understandings of risk, and how they manage that, and how they risk and kind of start to create new ideas in their worlds. So really, we've just had that one study we've managed to finish, and these other studies which are going and starting up, and hopefully we'll have some interesting data from there. So thanks. That's all I wanted to say at this point.
Okay, thanks, Andrew. Fascinating set of studies. We don't have any questions in the Q&A at the moment, so just a reminder to people to pop them in there as you go. But Andrew, one thing I'm wondering about, because talking to people, I've heard it both ways. What happened over time with the lockdown? Do you have a sense of that? Did people adapt and it got easier, or was it progressively more stressful, or is there a mix of those for people?
Yeah, I think from our qualitative interviews, if you were in the kind of middle upper classes, I think it got more stressful. There's an initial stress of going into lockdown, the initial kind of moments, and then you kind of got used to it. And as you eased off, as questions about how to manage risk of COVID infection became more prominent in their lives, anxiety, stress became harder. For those who are poor, who lost their jobs, the stress hit immediately, and I don't think it's ever really changed. You know, just the sheer kind of how you navigate not having food and money and making ends meet. So it eased off slightly as people could start looking again, but you know, huge kind of impact there.
So Paul, it's Jeremy. Susan had a quick question, but she's having problems typing it into the chat box. So maybe she should ask it.
Ask it, Susan.
Hi, I don't know if I'm alone in not being able to type into the chat box. Maybe somebody else could try it and see.
It's
The Q&A.
panel.
The Q&A.
The panel.
Yeah. Anyway, my question's about young people and complying with the restrictions, because in the UK, it's young people, especially young men, who find it most challenging. And wondering if this is also the case in your studies, and also if there's been any research about what kind of measures have been helpful in terms of supporting them to abide by the restrictions.
Yeah, I think in some ways the HSRC work has done some quite big surveys with young people. Just very quickly from the qualitative we had, I think adults who had children who were kind of teenagers who were used to being out and about did struggle to maintain boundaries during the most challenging lockdown. So mobility and seeing friends, especially where access to technology, internet is a bit more challenging, was hard. But I'm sure Alistair's probably got a lot more to say about young people.
Okay, well, that's a nice segue to our final speaker tonight, or today, depending on where you are, who is Alistair van Heerden, who's from the Africa Health Research Institutes. The Human Sciences Research Council, South Africa. Sorry, wrong line, Alistair. And he's done several studies during the COVID-19 pandemic. So, Alistair, over to you.
Great, thank you very much. Let's get screen shared. So I really have the privilege of talking on behalf of a whole range of my colleagues today, who have been very hard at work, as have people at the MRC and at RE. So some of the work that I'm going to talk about, the PIs are listed here on this slide. Just to briefly mention that the HSRC is the sort of sister body to the South African MRC. So we are the Human and Social Research. Oh, I can't even say what our name is. Human and Social Research Council, whereas in comparison to the Medical Research Council. What I decided to focus on was just to give a breadth of what data is out there from within our studies, and I will share a link where you could access some of the reports, early reports and papers that are coming out of this work, just given the timeframes that I had to speak. The HSRC have a fairly well-developed set of methods for doing national and regional surveys. And so that was really the early focus, was on trying to get a representative national sample of people's first knowledge, attitudes, and perceptions about COVID. And short on the heels of that survey was some of the experiences and social impacts of the very high level 5 lockdown that we had, which was very restrictive. Post those two surveys, there was also an interest in the healthcare professionals and just how our health system was going to cope. And so there was a fair amount of work looking at interviewing nurses and doctors and other healthcare professionals to gain their insights. And then much like what's just been presented by Mariam and Andy, also interested in the youth and the impact both on employment and on education. So those 4 surveys, there is data and reports available, as I'll share at the end. So just wanted to mention them. There is also some other smaller work around vulnerability mapping and the delivery of health services, but I think Mariam already spoke very nicely to some of the health challenges, particularly in a country with such high levels of HIV and TB. I wanted to briefly touch on some of the qualitative studies that have been going on. And I think what's been quite exciting, if I could use the word exciting, but what's pushed us is to sort of expand some of our qualitative methods, and rather just than our standard key informant interviews or focus groups, moving some of the work online, moving into sort of texting spaces, and exploring things like Photo Voice, where we have been having people sending us short videos or photos, sharing memes that shared with them, and then looking at interpreting some of what people take from those shared media content. And some of the interesting pieces, just to briefly mention here, really have been around housing, dignity, and food. And so that comes from the Life During the Lockdown study. There's also been a small amount of work on the side trying to analyze some of the social media data out there. Particularly, I think Twitter and Instagram were used in those cases, but I don't have all the details on that study, but could put you in contact with the PI of that if anybody wants to know more about that work. Interestingly, Mariam, Andy, and I didn't talk before. I thought what might be useful just to pull out what I feel are some of the key maybe areas that maybe differentiate in some ways the pandemic here in South Africa to other parts of the world. And I wanted to touch on age briefly. I think what's fascinating is that there's been a real focus on youth, and Africa is sometimes called the children's continent just because of how young and our demographic pyramid is. But obviously some of the real health risks are associated with the elderly. And I think for me, it's thrown into light just what a missing population the elderly are in some of our focus and work here in South Africa. And although there's been a lot of interest and focus on youth, sort of longevity and aging, it feels like that's something that we need to do better at, and characterizing that age group. Structural barriers are no surprise. We have real challenges in terms of abiding by lockdowns. Many people live in informal dwellings, and this is just a small stat from one of the reports where 21% of self-reported high-risk individuals living in informal dwellings were able to self-isolate. So that tells you that 8 out of 10 people don't have a space where they could just go and self-isolate. And these structural issues go way beyond this into public transport, people having to queue for grant support and financial support, people having to queue for their medications, and the risks associated with all of those activities, particularly, I think, in the health space, just because it was already a at-risk population who are now having to move around to access care. Alcohol was also another very interesting point, particularly in the policy space, because the HSRC got drawn into some very high-level legal cases around the legalities of. We had just a strict no alcohol policy, and the industry took the government to court at one point, and some of the HSRC work was used as kind of supportive of the ban on alcohol. And I think that, sorry, that point underneath there is not relevant, but alcohol has become a really interesting. At one level, there was a real drop in cases in hospitals from some of the gender-based violence that Andy was talking about. And on the other, there was this huge industry effort to try and open up, and people beginning then to illegally set up shebeens and produce alcohol illegally. So that was a very interesting component of the South African experience. Thinking of questions still to be answered, I think how we limit social harms and ensure that the efforts that we've made and the sacrifices that have been made so far are worthwhile really are front of my mind and some of my colleagues. We are in a strange place where cases are rising again, but it feels like there is very little support for another lockdown. And I think there's a challenge for all of us as we think about how to maintain the gains without a huge level of buy-in, I think, from citizens anymore for these hard lockdowns. So I think that that's something that's open to discussion. So all the data and reports you can access from the HSRC website there. There are two just that I mentioned, the series of rapid assessments and the frontline talk with the health worker report. And as always, this was not possible without our partners and funders. I mentioned a few on this slide. So that's a quick take on some of the HSRC work.
Great, thanks very much, Alistair. I'm going to hand over to Jeremy for questions, but going to sneak one in before Jeremy starts. And that's a very disturbing figure of only 21% being able to self-isolate. Did you have any qualitative data on what sorts of things people did to try and achieve some sort of self-isolation, or what they did to cope with that, to avoid infecting others?
Yes, so there were quarantine centers set up in South Africa where people were able to kind of, if they weren't able to self-isolate at home, could use those spaces. But that set in motion a whole another set of social concerns around being forced to isolate in one of these facilities without necessarily wanting to. And so that was another sort of fairly interesting piece of our puzzle, I think, is how do you create spaces for people but not necessarily force them into those spaces without them willing to go.
That's great, Alistair, thanks. I've got a follow-on, and then Molly Byrne has entered a question in the chat. So we'll go, I'll ask my question, and we'll ask Molly to come in. And I was thinking of, I mean, Thembi and Nesaya were very much talking about rural South Africa. And I'm kind of interested, is there a rural, what are the kind of differences between rural and urban? You know, because at some levels I can imagine there might be, some things might be easier in rural settings, some of those sort of maybe isolation or being able to live in an external environment, but some will be much more difficult. So I don't know whether, maybe Mariam, Thembi or Nesaya want to say something about the, their perspective on this kind of rural urban sort of experience, and then Alistair, if you've, or Andy, if you've got anything. I don't know who wants to go. Mariam.
I'll call on Thembi in a minute, but I think the rural experience, so some of the differences I think are quite stark. So some of the informal settlements that both Andy and Alistair are talking about, these are very compressed, extremely highly densely populated areas with a high number of young people as well. So very, very difficult, as they described, in terms of self-isolation. But on the other hand, there is better access to services, and the quarantine centres I think set up there were easier. In the rural setting, I think we didn't end up with a very large pandemic. The fear was there greater than the reality of it. But the key issues that came up, I think, were around economic possibilities. So most of the young people, there's more than 90% unemployment in our setting, in the rural setting. Most young people travel to cities for work, and during the lockdown, they were forced back into their rural communities, and there was a huge anxiety around employability going forward. So I think that became a big issue. And the second thing was, because there was so much activity around COVID, one of the things I think Thembi can talk to this nicely was people kept talking about why is, COVID must be terrible because we never did this for HIV and we're doing this for COVID. And so there was a huge amount of fear at the beginning and buy-in. And then when the pandemic didn't really pan out in terms of illnesses and sicknesses, it's been harder to really understand, I think, for people why they had to go through such hardship if it wasn't going to be quite as bad as what was said. So I think those were the key problems, and access to services is harder for us. We don't have ventilation, so there was greater fear. I think Thembi, you may want to add to that because you had quite sort of rich data from the peer navigators around these issues.
Yes, thank you, Miriam. So my video is off, sorry. So I think in addition to what you've said, so the rural setting, because people had moved from the urban setting where they were working and they came back home, the homes were not enough for everyone. So I think it was Andy who talked about issues of self-isolation, where those who had symptoms or assumed that maybe they may have symptoms or suspected, they didn't have any space, and they were even sharing beds, as reported by peer navigators who were talking to young people in their communities. So this limited, or it made the environment not conducive for them to participate in the COVID-19 rules, or to follow the COVID-19 rules. I think the other thing with the locals, both urban and local, now that South Africa has been declared and that it's going to a second wave, young people have been said to be leading in spreading COVID-19 infection during the second wave. And it's largely because of their mobility. And since schools reopened as the lockdown eased, young people are now closing schools, and they are having these year-end functions where they are gathered and they're having a good time, and then they come back home, and that's how COVID is spreading now in the second wave. I think I'll stop here. Thank you.
Also, share briefly on, if it's helpful, I'll just quickly looking through one of the reports. This is community type, and the questions are, I've been at home since the start of lockdown and have not left. You can see in the suburbs, 73% of respondents said that was true versus only about 50% in more traditional rural areas. I have had to leave to get food and medicines. Again, as we were just describing, 38% versus only a quarter in some of the other geographic types. I've had to leave to collect social grants, really only impacted informal settlements and more rural areas. And I've spent a lot of time visiting my friends and neighbors. Was pretty in lockdown 5, non-existent across all types of geographic communities.
Jeremy, on mute.
Sorry, I was saying thank you very much to Thembi and Mariam and Alistair. Really interesting. We've got a number of questions in the chat box. So I'm going to, or in the question and answer box. I'm going to ask Molly Byrne first. And you can unmute yourself and ask your question, Molly.
Okay, thanks, Jeremy. Thanks, everyone. Brilliant presentations. I'm interested particularly in the peer-led approach that Mariam and the team there are presenting. And, you know, I can hear from what you're saying that the young people who did get involved were very passionate about then adhering to the guidelines, it would appear. And I'm interested in what you feel were the main motivators in adhering to the guidelines. And I'm trying to understand better in terms of whether they were motivated to protect themselves or protect others, maybe older people, more medically vulnerable people who may be at higher risk. So my question is really around, what do you think are the primary motivators for younger people in adhering to the guidelines?
I'll start and then I'll hand over to Thembi because I think she can add to that. I think one key issue is that I think it was much more, and I'm sure Thembi will echo that, about protecting the community. I think there was a strong sense that young people were not vulnerable. That was fed quite early, and it was about protecting communities. These are a group that had been deeply engaged in HIV prevention, had been become sort of leaders in their HIV prevention intervention. So they see themselves as leaders in the community. The other thing I think that came across quite, and I was trying to sort of get across, is this sort of transition from being blamed for things, which has tended to be the situation under the HIV pandemic. It's always about young men, you know, going out and drinking and having sex, et cetera, to potentially having a role to do something, to be able to protect their grandparents, to, you know, be able to be the one that go out and do things. I think that becoming having a productive identity came out quite strongly in its work that we'd like to pursue in trying to see whether we can design interventions where young people, these peers, become actually caregivers in the community and support the wider families where families can't move around a lot. I think Thembi again can give a bit more colour to that.
Yeah, additionally, I think being part of the Africa Health Research Institutes made it possible for peer navigators to receive continuous COVID-19 information and updates, so they could relay this information back to their community members, including young people. And because they are staff members at ARI, they're also able to get data to access information and relay this information back to the young people who were anxious about the rumors and the mixed messages that they were receiving from the social media. So they were able to help young people navigate through the information that they were receiving and asking peer navigators about. I think I also wanted to say that what Miriam had said earlier, because they'd been providing sexual and reproductive health information and health promotion in their communities, they were the go-to person. However, they were also anxious about getting infected, about the other young people who were not following the lockdown rules, who were not wearing their masks, who were going out and hanging around in local talk shops and behaving as if everything was normal. It was difficult for them to go to approach those young people and convince them and talk to them about the regulations and why they needed to follow those strict rules. Thank you.
Great. Anybody else? Just a quick comment. We've got a couple more questions we want to get through. Okay, in that case, we're going to go on to Terry Kemple. So Terry, can you again just say where you're from when you start? Sorry, I didn't ask Molly to do that. So Terry.
Yeah, just unmuted. I'm Terry Kemple. I'm the past president of the Royal College of GPs. I'm mostly a retired GP, but I've been working for sort of the COVID telephone service since the pandemic started. And this is sort of a wider question, really. It's because clearly in all our countries, we've done loads of things which are completely wrong. And, you know, we're sort of living in this incredible era of misinformation, you know, where a lie travels around the world while the truth is still just getting its boots on type stuff. But the question I'm asking is, and what I'm really interested, you know, from where you're sitting in your part of the world and your particular population, what do you think, if we're planning for the next pandemic, what are the main lessons learned so far so that we can influence your population behavior better in the future, so that we can just manage this thing a whole load better? So I'm just interested from where you're sitting with your particular population, what you think you should be doing next time round.
That's the life, the universe and everything question. Anybody want to have a go at that to start off with?
I think Alistair should go for that one.
All right, Alistair, you've been gibbed on into this.
That's unfair. That's a very tough question. I mean, thank you for asking it. And I do like your perspective on thinking around how what we can learn from this round for future. I think that people here, again, I can only speak to what I know. I'll try and make some points of conjecture later, but people believed what messages were put out by government. And there was a very strong rallying behind those messages. And so I think that's something maybe that we did well, and maybe something that could be harnessed in the future, is just trying to make sure that we get key messages well described and then put out by a sort of authority body. As time has moved on, I think some of that has waned, and now there's just a mix of belief, particularly through social media and other channels. I think where the challenge happens in all health information is often when you try and change the message, that's when people start to stop believing. You know, as scientists, we all understand that the evidence changed and you update your view. I think for a lot of people here, once those first messages were out, that's what people kind of believed. And so I think being careful about what those first messages are and really using that opportunity is something that may be something we could take to the future.
I might butt in with a little bit. I think it's a lesson that probably translates to every setting, but in South Africa, the key lesson is that those structural vulnerabilities just became extremely enhanced. We've just seen what Andy described really nicely. I think Andy can come in there. The sort of class differences, the ability of some people to easily self-isolate. For others, it was a compression even in this rural setting, in a tiny house with lots of other people. It was a loss of the public space. Those structural inequalities just enhanced people's vulnerability to this virus, both from a physical perspective, but also just from the social and the sort of economic consequences. And we're going to see the repercussions of that going forward, I think. And I think the lesson we have is that we need to tackle those structural drivers prior to the next pandemic. Otherwise, we're going to end up in a similar position as we have been this time.
Yeah, I kind of fully agree. And I think what we see is almost, I think Alistair's right in that initial space, people listened to and followed government as best they could. But we also saw these kind of limits of governance and limits of statecraft and kind of blunt approaches. You know, the alcohol ban worked very well for a period, you know, but it took a while before illegal networks of alcohol sales got going. So I think, you know, as Mariam says, addressing these kind of major health structural barriers is critical. I guess the other thing is, and it's something I don't know really, but kind of reflecting that, you know, these health behaviors, the mitigation risks, the wearing of masks are really kind of identity work. And if we think about it as identity work, you know, and how we influence identity, and state structures aren't the way to influence identity work. So I don't know what that means for future pandemics, but I guess it's how we think about it, you know. But otherwise, I don't have much on that.
Okay, I think we've got about 5 minutes left, and there's 2 questions. So I'm going to we will try and rip through both of those. The first question, the next question is coming from John Overtight. John, I think we're trying to unmute you. There you go. You can now unmute yourself.
Thank you very much. I'll be very quick. I know there are issues about availability of vaccine, but separate to this, are there subsections of the population that may delay or resist COVID vaccines? And is there any experience from communicating and influencing some of these subpopulations for other types of vaccine that you might be able to share with us? I'll stop there.
So any experience about vaccine hesitancy in South Africa?
Again, Alison might know more about that. We haven't done much work on vaccine hesitancy yet. One thing to say that the HPV vaccine, for example, which has suffered in other settings, has had very high uptake in South Africa. So, and the childhood vaccinations are very well developed, distributed. Whether COVID is different because of the social media and the age that has to be reached is a different question. But I'll hand over Al. You might have something from.
Yeah, no, I think that's a good answer. I don't, at the top of my head, have anything else to add. There is a study that is just beginning looking at misinformation and COVID vaccine hesitancy, but that's just beginning, so I don't know the results. But I think you're right, Mariam, that typically vaccinations, particularly childhood vaccinations, are very well adhered to amongst most population groups in South Africa. So I think it's going to be less of a challenge potentially.
Okay, and Lucas, can we unmute Jenny Hanratty? I was talking to a colleague in South Africa, and one of the things that she was mentioning is, although in the north, this has become the thing that everyone is talking about, the kind of whole issue about the vaccine at the moment was less prominent in social discourse in South Africa and probably other African countries as well. But final question is going to go to Jenny Hanratty. So Jenny, over to you.
Hi, Jeremy. Thanks, everyone. I just wondered whether there's been much attention in South Africa paid to young parents and young mothers in particular when you're talking about young people's experience. So in the UK, when we think about young people, we generally are thinking about young, single, unmarried, unencumbered people, whereas young people in South Africa are much more likely to have children. So is there any differences between young parents versus young people without children?
Thembi, is that something you and Atsai may want to think about?
In Tsetanami, we didn't necessarily differentiate between young mothers and young people who do not have children. But what I can say is that generally, young people with or without children had more or less similar challenges with regards to not having data to connect, being stuck at home, the structural barriers that we talked about, where they needed to come back home and they were anxious about losing their jobs, and they were also anxious about moving around. And those who were at school were also stuck at home with their parents. One of the things that they mentioned, though, was being excited about the ability to also spend time at home with family members. And this also includes spending time with their children and doing things that they had not normally done with their kids when they were at home, and they developed new hobbies and spent time reading to their kids, doing gardens. So in that way, being at home was also helpful for them to spend time with their children. Thanks.
Great.
Okay. So from my side, our school-based study, we were looking mostly at the way they responded to COVID-19. So we had community group discussions with parents of school-going children, and we found that the combination of the group had middle-aged and older parents, and the main concern was on the fear of risk of transmission to elderly parents when the children come back from school. But the younger parents tended to understand the COVID prevention measures and messaging better. And they also understood the risk of infection was much lower in younger children, and therefore school-going children were safer in terms of COVID infection and transmission. And they were more concerned with things like how their children got to school and back, and commuting ideas. That's what they were more worried about. And then they were more relaxed when the Department of Education issued out some sanitizers and reinforced the messaging around trying to cut the transmission between parents and younger people. So children were from homes where they had elderly parents were given sanitizers and masks from school to protect themselves. So there was a motivation from both ends, the younger children reinforcing the messaging that they got from schools when they got home, and the parents being more proactive in terms of ensuring that their children got to school safely and in taking up the COVID messaging more seriously. So that's what I can say from the school-based end.
Great. And Andy, did anything come out of your sort of more domestic violence, gendered research lens?
No, it didn't. We haven't kind of looked at it like that. I suspect we would have found that we didn't actually interview many young kind of women with kids because of, the ease of doing interviews. It would have been very hard. I guess it kind of does raise this issue that there's a very quick movement to increase the social grant for people with small children who qualified. And one wonders how that impacted on young women's with children's experiences, opposed to kind of those who had to kind of introduced a COVID grant for anyone who wasn't receiving a grant, but that took a long time to get through and many delays and so on. So we might see some interesting questions around that. But yeah, nothing directly.
Okay, we're kind of at time, so we're just going beyond time. I apologise. Thank you so much. This has been a fascinating webinar. I think some of the issues are kind of what the similarities or differences that the South African society is experiencing, and the research challenges that raises to other sort of settings that we've heard from. So really a huge thank you to Mariam, to Tembe, to Natsaya, to Andy, and to Alistair. It's been a fascinating session. And just to remind people, this is the last BESI webinar for this year, but we will be convening in January. We will send out the data as soon as we've got this, where we really want to have a discussion with the people who've been coming to these webinars about, well, what we do with BESI, what's the future of BESI, what can we do that would help advance the research agenda and the knowledge to support societies both during the current pandemic and for future pandemics. So thank you so much to our South African colleagues. It's been a fabulous session. So I hope everyone has a good break over the holiday season, and we come back refreshed to 2021. And 2021 is a more interesting and hopefully less stressful year for all of us next year. So thank you very much. Goodbye.
Bye.